In this lecture recording covering urinary and renal disorders, we're going to be looking specifically at glomerular nephritis, nephrotic and nephritic syndrome, and acute and chronic renal failure. First off, though, we're going to look at some important terms, and we're going to match them. The first term is creatinine. Creatinine is the main waste product of protein metabolism. Creatinine clearance is a measure of renal function. So if you suspect that someone has kidney problems, they can be given a dose of creatinine to see how much of it goes through the kidney and into the urine. If it doesn't pass through as expected, it could indicate a kidney problem. Urea is number 8 here. Urea is a waste product of energy metabolism. Blood urea nitrogen, or BUN, is also a test that can be done to look at measure of renal function. But in addition, it measures glomerular filtration rate and urine concentration capacity of the kidneys. Glomerular filtration, remember, this will come up again. The glomerulus is that capillary network that's going to be filtering your blood, putting what's called filtrate into the renal capsule or Bowman's capsule, which will then pass through the tubular system of the nephron. So let's add 2 here. So well-functioning kidneys should be able to excrete urea. And if they are injured, for example, your kidneys, and they can't excrete the urine, then what we'll see is higher levels of urea nitrogen within the blood. The term lipid urea, lipid refers to fat. When you see urea, U-R-I-A, it's referring to urine, which is different than U-R-E-A, just so you don't mix the two up. Lipid urea is, as the name suggests, the loss of lipids within the urine. And lipids should not be present in the urine, so this can occur with certain kidney conditions. Albumin, we've talked about albumin before and even in normal anatomy. This is a very important plasma protein that helps regulate osmotic pressure and therefore water retention in blood vessels. So what that means is that albumin is a protein that is produced in the liver that will circulate within your blood vessels. And it's too large of a protein to leave the vessels. So when it stays there, it creates an osmotic pressure. It's more true to say an oncotic pressure or colloid pressure. But in any case, it's encouraging fluid, plasma in particular, to remain within the blood vessels. So if we have less albumin than normal within our blood vessels, we're more likely to lose fluid from our blood vessels. And we talked about that in an earlier lecture in our digestive system unit. And so people that have low amounts of albumin in their blood are said to have hypoalbuminemia. Hypo is low, albumin is the protein, and emia refers to blood. So that's relating to number 6 here. And if you remember from our lecture on the digestive unit, we talked about how this leaking of fluid out of the vessels because of low albumin can cause fluid to build up in the interstitial spaces or outside of the blood vessels. Polyuria, this is excessive urination. This is urination. This is referring to a lot, so excessive urination. And then we have oliguria. Oliguria refers to insufficient urination. So not producing enough urine to keep the body in homeostasis. Quick anatomy refresher. Remember that the nephron is the functional unit of the kidney, and there is roughly 1.2 million per kidney. These are the units that are going to be ultimately concentrating the fluids that go through it to produce urine. And remember, we have the glomerulus here that receives blood that gets filtered into Bowman capsule. Then it runs through the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct, which will then join in with the renal papillae, or the pyramid papillae of the kidney, and then it will work its way through the collecting system to eventually leave the kidney. We also have this peritubular network of vessels that runs around, and it's going to be reabsorbing fluids and solutes that we want to keep, returning it to our circulation. It would interest you to know that we filter roughly 180 liters of fluid a day through the glomerulus, or the multiple glomeruli throughout our kidney. But then we reabsorb about 99% of it, and we only get rid of a small amount. But the whole purpose of running through here is to allow for rapid clearing of anything that's foreign or anything that we don't want there. And it allows for very precise control over the composition of body fluids, ions, and water in particular. Our first condition of this lecture is called glomerulonephritis. The nephr part is referring to kidney. Glomerulo is referring to the glomerulus, that capillary network, and itis is inflammation. So this is inflammation of the glomerulus. And remember, it's the glomerulus that's going to be filtering our blood, putting substances into the capsule, Bowman capsule, that's called filtrate, which will travel through the tubular system of the nephron. With glomerulonephritis, what we see is damage to the glomerulus, or the capillaries that make it up, but there's also damage to the glomerular basement membrane. Remember that capillaries, and these are capillaries, just like all blood vessels, have an endothelial layer. And endothelial is really an epithelial layer, but it just gets a more fancy name when we're talking about blood vessels. So we can have damage to this structure. Now, if this progresses, or if it becomes severe enough, it can lead to renal failure. In fact, glomerulonephritis is the most common cause of end-stage renal failure. Some common causes include, we're looking at both primary and secondary. So primary could be that there's an altered immune response within the body, ischemia, free radical damage, drugs, toxins that are damaging, an infection that causes damage, and a disorder of blood vessels. Some secondary causes that lead to injury of the glomerulus are related to systemic diseases. So, for example, diabetes mellitus, hypertension, bacterial toxins, systemic lupus erythematosus, congestive heart failure, HIV-related kidney disease, and so on. These conditions, these systemic conditions, can affect the function of the glomerulus. And what ends up happening is the kidneys start to shrink and they appear quite small compared to normal. And they also have this finely granular external surface that you can see. Still talking about glomerulonephritis, we're going to look at some of the changes that occur with this condition. And it includes abnormal movement of proteins and red blood cells into the urine. And normally, proteins and red blood cells are too large to be passing through the glomerulus. So they're too large to be filtered through here into the Bowman capsule, and so they exit the glomerulus and then just remain part of our systemic circulation. But if the glomerulus, this capillary network, is damaged and it now allows for the passage of larger substances to be filtered out of the glomerulus and into Bowman capsule, they can make their way through our tubular system and become part of our urine. So first off, protein in the urine. This is more appropriately called proteinuria. And this occurs primarily because of loss of negative charge across that glomerular membrane, the capillaries membrane. Under normal circumstances, when working properly, the negatively charged glomerular basement membrane is normally going to repel the negatively charged proteins. And that's going to stop them from crossing into Bowman's capsule and then ending up into the urine. But when it comes to blood in the urine or red blood cells, which is what we call hematuria, this primarily occurs because now we have an increase in the size of the pores. Normally, pores are far too small for structures such as protein and red blood cells to pass through. And when the pores open up, then we're allowing substances to pass through and end up in the tubular system and then end up as part of our urine. We also know that with glomerulonephritis, the basement membrane of the glomerulus can be damaged. And what this does is it reduces the surface area of the capillaries, which decreases glomerular filtration rate. We know that a large surface area is going to maximize really any process. And so what this does is it leads to a reduction in glomerular filtration rate, leading to accumulation of waste products in the blood that should normally be filtered at an appropriate rate through the nephron and end up as part of the urine. So urea and creatinine are examples. We talked about those, introduced those earlier on our term slide. And so from a testing standpoint, we would see a reduction in creatinine clearance, but we would also see an increase in urea and creatinine in the blood. In addition, decreased glomerular filtration rate means that if we're putting less fluid into our urine, it has to go somewhere. So instead, it's going to remain within our blood. And when you increase the volume of fluid within blood vessels, it's going to increase pressure. Volume and pressure are directly related. So you increase volume, you increase blood pressure. If you decrease blood volume, you decrease blood pressure. So when we have an increase in blood volume, because we can't get rid of it in the form of urine, it can lead to high blood pressure or hypertension. And finally, a decreased glomerular filtration rate will lead to oliguria, which is that very low output of urine, so roughly 30 milliliters per hour or even less. Normally, we will get rid of upwards of 1.5 liters per day, just as a comparison. And overall, this can lead to edema. It can lead to renal failure that can start off as acute and end up becoming chronic. There are two types of glomerulonephritis, nephritic syndrome and nephrotic syndrome. And really the difference in the name is very slight, so make sure you pay attention to that. There are three causes of nephritic syndrome. The first one being a type 3 hypersensitivity, which is the majority at 90%. Remember from learning about hypersensitivities that with a type 3, we have a soluble antigen from a bacteria that can form an immune complex that becomes large enough to deposit itself into tissues. And when it does this, it lands on the glomerular basement membrane here. And then it's going to be opsonized, and what that does, if you recall, is it's decorating the immune complex, making it more attractive to our immune system. And so white blood cells, leukocytes such as macrophages and neutrophils are going to see it, think it's attractive, want to eat it, and come to destroy it. And in doing so, because this immune complex is stuck to the basement membrane, our immune system, our leukocytes, end up destroying the basement membrane in the process of destroying the immune complex. This leads to a reaction called endocapillary proliferation. So really the inner part of the capillary start to proliferate, and mesangial cells, which are the contractile cells of the glomerulus, start to proliferate. When these two occur, it's indicative of damage to the glomerulus and nephritic syndrome. Now the second cause, much less, is due to a type 2 hypersensitivity. This is where we have antibodies that are formed against the glomerular basement membrane, so anti-glomerular basement membrane antibodies. and they form a connection with the basement membrane or the glomerular basement membrane, and then you have the leukocytes that come in and end up destroying the basement membrane unintentionally. And so we get accumulation of both immune deposits and inflammatory cells and other debris that can extend into Bowman's space, that capsular space, and form lesions. A third cause is due to inflammation, and it can be due to a variety of reasons such as ischemia, drugs and toxins, various vascular disorders, other systemic conditions such as diabetes, and systemic lupus erythematosus. Now let's look at the effects of nephritic syndrome and what we typically see. And this is very important. First of all, we're going to see an increase in the size of the pores of the basement membrane of the glomerulus. And so this is going to increase its permeability, allowing substances through. Specifically, what we will see is blood in the urine. This is because a lot of red blood cells are going to end up passing through. You can also see components of white blood cells as well. But what's really interesting is that there's little or no proteinuria with nephritic syndrome. Now, why is that? Well, because even though we have this increase in the size of the pores that would theoretically let protein through it, we've maintained a negative charge of the glomerular basement membrane. And this negative charge is going to repel the proteins, preventing them from moving through the pores and ending up as part of the filtrate and ending up then as part of the urine. That is very important for you to know. We're also going to see a reduction in capillary blood flow and glomerular filtration rate, and all of this can result in renal failure. The second type of glomerular nephritis is nephrotic syndrome. There's that slight difference in the name. This condition or this state is usually idiopathic. Remember, that means that there isn't a known cause, but it is more common in children than adults. It can be associated in terms of knowing a cause with certain drug use, such as nonsteroidal anti-inflammatory drugs, certain infections, can be related to malignancies and other vascular disorders. But with nephrotic syndrome, we don't see the immune deposits. So the glomerular basement membrane really appears rather normal. But what we do see is thinning, uniform diffuse thinning of epithelial foot processes that are found as part of the glomerulus. These are called podocytes. Podocytes that have these little pedicels that are feet. Podocytes, which you can see here, and this is your capillary endothelium. These podocytes are going to work with those mesangial cells that I mentioned earlier, those contractile cells. And what they're going to do is support the overall structure and function of the glomerulus, but they form a filtration barrier. So if all of a sudden we have thinning of a filtration barrier, it's now going to permit substances to move through it that otherwise are prevented. In terms of direct effects of nephrotic syndrome, we see that the negative charge of that glomerular basement membrane is lost, and now proteins cannot be repelled from entering into the capsular space and ending up then in the tubular system and ending up as part of our urine. And so this creates what's called severe proteinuria, which is different than what we saw with nephritic syndrome. We shouldn't have protein in our urine, but up to 3 to 5 grams per day can be seen, with the main protein, as already mentioned, being albumin. And so albumin will end up in the urine in large amounts, and we call this macroalbuminuria. For some reason, there is very little hematuria with nephrotic syndrome. So you can certainly see the differences between the two types of glomerular nephritis, nephritic syndrome and nephrotic syndrome. Let's have a look now at some of the indirect effects of proteinuria with nephrotic syndrome. Now I want you to just listen for a moment. thinking back to normal anatomy, you should or may recall that when blood is pumped from the left side of the heart to the tissues, where we get to the level of the capillaries, at the arterial end of the capillaries, there's going to be sufficient pressure that exists to filter the blood and the fluid out of the vessels and into the tissues, because that's what we want. We want to bring the tissues nutritious blood with oxygen. Then at the venous end of the capillaries, this is where we want to encourage reabsorption, taking back that fluid, taking back waste products and that deoxygenated blood. And so what we see then is at the arterial end of the capillaries, we want filtration to occur into the tissues. At the venous end of the capillaries, we want to encourage reabsorption back into the venous end of the capillaries and into the venous system. And you might also remember that the venous end doesn't pick up all the fluid. It does leave a little bit behind that the lymphatic system will pick up before putting it back into the venous system. The pressure differences that exist between what's in the blood vessels and what's in the tissue is going to govern the movement of this fluid. And so these pressure differences are necessary in order for us to have filtration and reabsorption occur. And so loss of albumin within the blood vessels is going to encourage fluid to leave the vessels at both the arterial and the venous end. And so instead of taking back that fluid from the tissue to return it to our venous system, it sits there. It sits in between the tissues because we cannot pick it back up. We've lost the pressure that's created from albumin, which encourages fluid to be within the vessels. We've lost it because of nephrotic syndrome, with protein ending up in the urine. And so these are a few examples of presentations that could exist when we see this loss of albumin causing swelling within the interstitial spaces. Swelling in the face and swelling in the abdomen. In the face here, it's called periorbital edema. So around the orbit, we have swelling. And then in the abdomen, you should recall that this is called ascites. So that's the first indirect effect. The second indirect effect that we see with proteinuria is that normally proteins are going to bind to hormones within your blood, including thyroid hormone and other lipophilic hormones, allowing for the transport of these hormones. Examples of lipophilic hormones include sex hormones, glucocorticoids, and aldosterone. And so if they're lipophilic, it means that they're hydrophobic and they can't transfer well within our plasma because plasma is mainly water. And we know water and fat don't like each other. They don't attract. So we need some sort of carrier to take these structures, these hormones, in the blood to their destination. And so proteins do that. But if we lose proteins in the urine, we have less available to do so. It's like we've lost our transport system. The highways still exist, that is the blood vessels, but the cars that are taking you to where you're needing to go are not available. Effect number 3, because of the loss of proteins, there's also going to be an increased synthesis of hepatic lipoproteins. So these are produced by the liver, leading to a state of hyperlipoproteinemia, so high amounts of lipoproteins in the blood, and a state of lipiduria, which is the loss of lipids in the urine. So although there are other effects, these are 3 main effects to be aware of. Next up, we're going to talk about acute renal failure, and the 3 types that exist are pre-renal, intrarenal, and post-renal. The name itself gives you a bit of an idea of what's involved. Pre-renal acute failure is the most common cause of acute renal failure, and the cause of this is going to be an impairment in renal or kidney blood flow. So the kidney is not getting the proper blood flow it needs. That's why it gets the name pre-renal. And why is it not getting enough blood flow? There could be a number of causes. Somebody could be in shock. There could be a case of ischemia or hemorrhage, or maybe a low cardiac output where the heart is not pumping out as much blood during a particular time that it should be. So a change in stroke volume and heart rate. Intrarenal acute renal failure is going to involve a problem within the kidney, hence the term intra. And it's going to more specifically involve the renal tubules, and in some form they become injured. And there's a state called acute tubular necrosis where you have death of the tubular epithelial cells. And this is an effect that can occur after somebody has surgery where they experience ischemia or nephrotoxins that damage the tubules. And then post-renal is, you can think of after the kidney compared to pre, so the problem is after. And in this case, there would be some state where bilateral kidneys, so both kidneys are obstructed, leading to failure of the kidneys. In any case, though, all three of these types of renal failure are going to result in a reduction in glomerular filtration rate and a reduction in the production of urine oliguria. Let's have a look at the pathophysiology of what we just spoke about with acute renal failure. Let's say there's exposure to nephrotoxins or a state of ischemia, reduced blood flow. This can, as we talked about, damage the tubules. And when it damages the tubules, it can actually cause the cells that make up the tubes to detach, and they can end up in the urine as what are called casts. And so urinary casts are just these tiny tube-shaped particles that can be found in the urine when it's examined under a microscope. And casts can be made up of a variety of different things. Could be white blood cells, could be red blood cells, but in this case, the casts are made up of tubular cells that have detached. So when you see those in the urine, that's clearly an indication that there's damage to the tubules. Ischemia or nephrotoxins can also damage the glomerulus so that it becomes less permeable and doesn't allow for the normal passage of fluid and solutes. What we'll see next is a reduction in the overall glomerular filtration rate. We can't properly filter fluid through that glomerulus and into that Bowman capsule to then pass on into the tubular system. And so if we're not filtering enough fluid from the glomerulus into Bowman capsule, then we don't have a high enough pressure difference between the glomerulus and the tubules that would be just distal to it. And so we end up with a bit of back pressure against that glomerulus. Overall, what this is doing, though, is leading to renal insufficiency. We can't properly clear out substances that need to be cleared because of that reduction in filtration. So we'll see an increase in blood urea nitrogen. We'll see an increase in the presence of serum creatinine. We'll also see an increase in urea in the blood, uremia, which is referred to as uremia. Renal failure can result. One of the first indications here is that reduction in urine production. And then if it persists, you can get to the point of end-stage renal failure, and that can be life-threatening. Let's look at the phases and recovery of acute renal failure. The big one that we'll see between days 1 and 21 is going to be that reduction in urine production. And if we're producing less urine, so we have a reduced urine output, then we're going to see an increase or an accumulation of waste products within the blood because they can't be filtered and put into the urine. And so we'll see an increase in blood urea nitrogen and an increase in creatinine. During the second phase here, the diuretic phase, this is really when recovery can start. But here we're still seeing tubular damage present, and it's important for fluid and electrolyte balance to be a treatment that's in place. And the reason for that is because there will be a state of diuresis, which is excessive loss of water once the kidneys start functioning better. Within 3 to 12 months during the recovery phase, assuming that damage was not too severe, some can fully recover, but in other cases, full recovery does not occur. But in any case, plasma creatinine does need to be monitored closely. The primary goal of therapy and treatment with acute renal failure is to maintain that individual's life until they have recovery of their kidney function. And so making constant corrections with the person's fluid and electrolytes, treating any infections that might come up and getting them under control, maintaining nutrition to make sure there's no deprivation in that area, and then remembering that any drugs that are administered are not going to be excreted properly, and that can become toxic to the body. Chronic kidney disease is the progressive loss of renal function that has the ability to affect nearly all organ systems, and it's associated with systemic diseases such as hypertension, diabetes mellitus, systemic lupus erythematosus, or just lupus, and intrinsic kidney disease. In any case, though, what chronic kidney disease will involve is a reduction in glomerular filtration rate. And we know that this is going to lead to an accumulation of waste products in the blood, seen with higher levels of creatinine, as well as urea nitrogen. Now, the kidneys have this remarkable ability to adapt to loss of nephron mass, because we know that we have upwards of 1.2 million nephron per kidney, and not all of them are going to be damaged in especially the early stages of chronic kidney disease. And so what is evident is that some of the other nephrons, the healthy nephrons, are going to undergo compensatory hypertrophy, and so they can compensate for the injured nephrons. And so what we see with these nephrons is hyperfunction in terms of their filtration abilities, their secretion and reabsorption abilities. Now, this compensation, of course, would be seen more earlier on in chronic kidney disease. So even though we are likely to see that there is protein in the urine and maybe blood in the urine and other cells and substances that normally shouldn't be part of the urine, that's because of the injured nephrons. But the uninjured nephrons are still going to be able to help maintain our fluid and electrolyte balances and our acid-base balances in earlier stages. I'm going to skip over increased capillary permeability for a moment. I will come back to it and look at hyperkalemia. Hyperkalemia, which is high levels of potassium in the blood, is a frequent finding in patients with chronic kidney disease. And this increase in potassium levels is associated with a reduction in renal ion excretion. And so we get rid of less, so more remains in the blood. But also, there are medications that are used to reduce the progression of chronic kidney disease, or maybe medications that are used to control these systemic conditions, which can also lead to hyperkalemia. And hyperkalemia, this high level of potassium in the blood, is concerning on a number of different levels, including the risk of cardiac arrhythmia and even sudden death. As chronic kidney disease advances, changes in acid-base balance can start to occur, and this can affect phosphate and calcium balance. Specifically, this imbalance involves a reduction in our excretion of phosphate and lower levels of calcium in the blood. And this combination can lead to many different effects, including but not limited to bone dissolution, which would increase somebody's chance of suffering from fractures. Because blood can be lost in the urine, this can lead to a state of anemia because it's a chronic state of blood loss. And those that are anemic are going to suffer from symptoms such as lethargy, so extreme feelings of tiredness, dizziness, and a low hematocrit level. Hematocrit, you might remember, is the volume percentage of red blood cells in blood that can be measured with a blood test. Now, to this last point, two factors that have been consistently recognized in advanced renal disease or advanced chronic kidney disease involves proteinuria, which we've talked about, as well as angiotensin II activity. Now, this protein in the urine is going to be a result of a few different things. One is we talked about that hyperfiltration that can occur in states of chronic kidney disease. There's also increased capillary permeability, and we'll talk about one of those causes in a moment. And there's also loss of that negative charge of that basement membrane, which doesn't allow the proteins to stay within the blood vessels, and they can instead leak out. Before I talk about angiotensin II activity, which is evident in chronic kidney disease, a couple of normal anatomy reminders. We have this vessel here, which ultimately is a branch of the renal artery, and this is called the afferent, so with an F, afferent arteriole. So a small blood vessel that brings blood to all the different glomerulus or glomeruli found within the kidney. Gets filtered here if pressure is high enough, which in normal cases it is. And then we have the filtrate that ends up out here, and then it moves through our tubular system. Anything that is too large to be filtered through here will exit the glomerulus through the efferent arteriole. So that starts with an E. And that should include substances like red blood cells and even proteins. So we have what's called a renin-angiotensin-aldosterone system. That's the RAAS that you might recall from normal anatomy. And this is a system that can impact the function of our nephrons. What's seen in chronic kidney disease, though, is that angiotensin II activity occurs, so it's activated by this renin-angiotensin-aldosterone system, and its effect that I want you to make note of is that it causes this efferent arteriole to vasoconstrict. And when it constricts, you might be able to see that what this is going to do, if it's not allowing blood to properly move through here, it's going to increase pressure here because it now can't move properly through this constricted vessel. So it builds up through here. And this is going to be what contributes as well to that increase in filtration that can be seen with some of the healthier nephrons. But over time, what this can do is lead to hypertension, glomerular hypertension. It can start to damage the capillaries, leading to an increased capillary permeability, permitting certain substances, such as proteins and red blood cells, to become part of the urine. The clinical manifestations or systemic effects that we see with chronic kidney disease are oftentimes described using the term azotemia and uremia. Azotemia is manifested by an increase in the levels of urea and creatinine and other nitrogenous waste products that are related to a reduction in kidney function. We can't clear it out, so it accumulates. Now, uremia is really a pro-inflammatory state where there's going to be many systemic effects that are seen throughout the body, and this is what we call uremic syndrome, when we start to see systemic effects caused by the pro-inflammatory properties of urea not being excreted, but instead being present in high amounts in the blood. Fatigue, anorexia, so weight loss, nausea, vomiting are common. Toxic encephalopathy because we're not able to get rid of waste products, so they accumulate in areas of the body, including the brain. These substances can also accumulate these waste products within the skin, leading to itchiness. That's what pruritus is, as well as causing abnormal pigmentation within the skin. The skeletal system can be affected, as we have talked about a little bit already, where you can be prone to fractures, bone pain, and long bone deformities as we get bone dissolution occurring. Immunosuppression is a common effect as well. But what we can see from this slide here is this is not an exhaustive list. We have many different potential effects that can occur due to chronic kidney failure. The most common cause of kidney failure, and I have already mentioned this, but it's important to make note of it, is diabetes mellitus. In terms of treatment, it's going to vary, of course, depending on severity, but preserving any remaining functional nephrons is going to be of utmost importance. Dialysis is going to be required in order to clean the blood, since the kidneys cannot do that, and transplantation, kidney transplantation, is likely as well. But what we get at end-stage chronic kidney failure is this irreversible loss of renal function that ends up affecting all different systems in a variety of different ways throughout our body. And so I do want you to know that it can affect all different systems in our body, but the specific details that I need you to be aware of are outlined on this slide. Okay, that is the end of this lecture on urinary disorders. Thank you for your time. Have a great day.